Then realize.
Good evening, doctors. I am Dr. Namra Sheikh, medical advisor with Emcure Pharmaceuticals. I welcome you all to the digital platform for another exciting session on no thrombosis workshop series on stroke. It gives me immense pleasure to welcome our course director for today's session, who is Dr. Richi Poria. Sir is the director of the neurology department at Sahyadri Hospital. Sir has set up the first neuro ICU and the neurointensive care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India and has credit of multiple delivering public lectures and workshops on stroke. He is the founder of the Pune Stroke Group and the ex-president of the Society of Neurosciences. He's been the principal investigator for multiple multinational stroke trials and has been awarded as the health icon by the Times of India Group. We welcome you, sir. Thank you for being today.
Thank you so much.
I would now like to introduce Dr. Prasanna Koregaonkar. Sir is the moderator for today's session. He is the professor and HOD of Neurology Unit at the GMC Meerut. Sir is an experienced neurologist with distinguished career spanning over 3 decades. He has completed his MBBS and MD in internal medicine from Shivaji University and has pursued his DM in neurology. Sir is actively involved in clinical practice and academics and is presently associated with the Vanless Hospital Meerut and GMC Meerut. In addition to his clinical roles, he has contributed significantly to medical education and was a lecturer at the Government Medical College Meerut and has served as a postgraduate teacher and examiner in medicine at MUHS Nashik. We welcome you, sir. Thank you for being on board.
Thank you very much.
I would now like to introduce our second moderator for today's session. Sir is the chairman and the consultant neurologist of CNS Hospital Solapur. Sir is a member of the Academy of Neurology, the member of Indian Academy of Neurology and the Maharashtra Academy of Neurology. Sir has a teaching experience expanding for up to 5 years in the Department of Pediatrics at Dr. VM Medical College and CSM General Hospital, Solapur. Sir is an experienced healthcare professional and has been awarded the Healthcare Professional of the Year in 2017, the Luminaries Award in 2018, and multiple others in 2018. We welcome you, sir. Thank you for being on board.
Thank you so much.
Yeah, thank you for the kind invitation and very, very warm welcome to Dr. Nathaniel Sase and Dr. Prasanna Koregaonkar, who are very eminent neurologists in Maharashtra and are very good friends of mine. This no thrombosis program has been running now, I think, in its second year, and 16, 17 monthly no thrombosis programs have occurred. And I must say that I have learned a lot from them, and I continue to learn a lot from them. And I'm sure today we will have a very exciting session. And I would request the moderators to actively participate and quiz the speakers with their cases. So if we can continue and start, you can introduce the speakers and then who's going first, Dr. Pandey or Dr. Krishnan?
Right, sir.
Yeah,
Our
okay.
speaker
Dr.
for today's session, the first speaker is Dr. Ramesh Krishnan. Sir is Senior Registrar in the Neurology Department at Indraprastha Apollo Hospital. Sir is presently pursuing a DRNB neurology at the Indraprastha Apollo Hospital and has completed his DNB in general medicine and MD in pharmacology. And so when it comes to clinical experience, he's managed several COVID-19 wards and ICU independently. He's skilled in lumbar puncture, pleural tapping, tracheostomy, and has extensive experience in diagnosis, treatment, and critical care. When it comes to skills, he is skilled in respiratory intensive care patient assessment and emergency management. We welcome you, sir. Thank you for being on board.
Thank you, ma'am. Thank you.
Our second speaker for today's session is Dr. Shishir Pandey. Sir is the attending consultant at the Department of Neurosciences in the Prastha Apollo Hospital, New Delhi. When it comes to a clinical experience, he has been the senior registrar of the neurosciences in the Prastha Hospital and senior resident in internal medicine, junior resident in internal medicine at Sanjay Gandhi Memorial Hospital, Rewa. And he has a credit of multiple publications in national and international journals, as well as poster presentations in national and international conferences. We welcome you, sir. Thank you for being on board.
Thank you. Thank you, Dr. Amra.
Without much ado, I would now like to hand over the session to Dr. Richa Poria, sir.
Now we go on to Dr. Krishnan's case.
Good evening, sir. I am Dr. Ramesh Krishnan from Indraprastha Apollo Hospital, and my case is on a stroke in young, a rare conundrum. Miss Baisali, 22-year-old right-handed female. She was a resident of Haryana and a MBBS final year student. She came with presenting complaints of intermittent bluish discoloration of her fingers of both hands as well as perioral area since 4 years. She had also complained of easy fatigability, which increases on exertions since 4 years. She visited local physicians for her symptoms. She underwent regular checkups along with chest x-ray, but nothing conclusive came. She was still having fatigability with bluish discoloration of her fingers, as well as the perioral area with SpO2 of 78% on room air. This bluish discoloration was not cold to touch with no seasonal variation noted. She used to manage her routine activity of daily living in this state of health since 4 years. In the afternoon of 5th of December 2024, she suddenly developed tingling and numbness of her both hands up to the wrist, as well as the perioral area with associated slurring of speech. She was completely aphakic for about 5 minutes following the events. However, she could comprehend well during the events. These symptoms lasted for about 15 minutes with complete resolution of her symptoms. She did not complain of any weakness in the limbs, any facial asymmetry or blurring of regions, or any abnormal movements, as well as loss of consciousness during the events. This was the NCCT brain, which was done on 5th of December 2024, which showed hypodense area in the right basal ganglia. This was the MRI, which was done on 7th of December 2024, which showed acute on chronic infarct in the right gangliocapsular region. We retrospectively took the history of easy fatigability on exertion. She noticed becoming dyspneic while climbing the stairs and lag behind her colleagues. It was insidious in onset and was non-progressive. It was not associated with any cough or sputum. It does not aggravate during winters or early morning hours on an exposure to dust or pollens, with no diurnal variations or any positional variation of her symptoms noted. However, it aggravates on physical exertions and relieved upon taking rest. There was no history of chest pain, syncopal attacks, swelling of legs, facial swelling, decreased urine output, pain abdomen, or any history of yellowish discolorations of eyes or abdominal distension, or any history of sudden loss of weight, any joint pain, a skin rash, or fever noted. There was no past history of similar illness. She consumes mixed diet with normal sleep and appetites, with normal bowel and bladder habits, with no history of any substance abuse. There was no similar complaint in the family, but his mother had history of tuberculosis during her pregnancy. There was no history of pneumonia, asthma, heart disease, hypertension in the family. Medical history, there was no history of diabetes, tuberculosis, pneumonia, asthma, or heart disease or hypertension. Then what differentials you will consider at this point of time with the patient having dyspnea on exertion, central cyanosis, as well as TIA. Our differentials would be ventricular septal defects, protraction of aorta, teratology of Fallot, total anomalous pulmonary venous drainage, hypoplastic left ventricles, pulmonary vein stenosis, persistence of foramen ovale, and pulmonary arteriovenous fistula. In all these differentials, the patient will have shortness of breath with central cyanosis, as well as there can be history of TIA. TIA can also occur. On examination, my patient was conscious, cooperative, and well-oriented to time, place, and person with weight of 55 kg and height of 172, with BMI of 18.6. With cyanosis and clubbing were present, with no pallor, icterus, lymphadenopathy, and pallor edema. As we can see, the cyanosis and clubbing, which is evident in this figure. Pulse was 90 beats per minute and was regular. BP was also normal in all the four limbs in supine and after standing for about 3 minutes. Respiratory rate was 20 beats per minute. JVP was not raised and no distended vein in the necks or chest. Then what differentials you will consider at this point of time? Now patient has another positive findings, that was the clubbing. And with clubbing, these all differentials that the patient had the shortness of breath, central cyanosis, and TIA, with positive findings being clubbing added, will all my differentials will have the clubbing. Still, I am not at the point where I can conclude the provisional diagnosis. On CNS examination, at the time of CNS examination, at the time of examination, when I was examining was normal, with cranial nerves being normal, higher mental functions were normal. Power was 5/5 in all the four limbs. DTR was 2+. Planters were bilateral flexors, sensory, cerebellar, and meningeal signs that all were normal. CVS examination was normal in my patient, with the apex vict in left fifth intercostal space medial to mid clavicular lines, with S1, S2 heard, and no murmur were present. Now, what differentials you will consider at this point of time with one negative findings which was added, that was the CNS examination being normal in my patient. Here we can see that the CNS examination was normal, and in all my differentials, like ventricular septal defect, we will have holosystolic murmur at the lower left sternal border. Protraction of aorta will have systolic ejection murmur in the back below the left shoulder blades. Tetralogy of Fallot will have systolic ejection murmur of PS and holosystolic murmur of VSD. Total anomalous pulmonary venous drainage will have systolic ejection murmur at the left sternal border with prominent second heart sound. Hypoplastic left ventricle usually does not present with murmur, but it may present with systolic murmur at the left sternal border. Pulmonary vein stenosis will have crescendo, decrescendo, ejection systolic murmur, and have faint systolic murmur. And my one was the persistent, where one was the pulmonary arteriovenous fistula that is not visible in this slide. It will have no murmur. Means at this point of time, means all my differentials, most of my differentials will have a CVS examination being positive. Only the persistent arteriovenous fistula and hypoplastic left ventricles will have no murmur, or the persistent foramen ovale which will have faint systolic. We did the respiratory examination, and the respiratory examination was shape of the chest was normal, percussion normal notes on the both sides, breath sound was vascular and equal in all areas, with vocal resonance normally in both sides, but roots were present in the right interscapular regions. On the right side, there was roots were heard on the right side. Now, my patient had dyspnea exertion, central cyanosis, TIA, clubbing with serious examination being normal, and roots were present on respiratory examination. With these positive findings, of the roots being present in my respiratory examinations, rule out all my differentials like ventricular septal defects, contraction of aorta, teratology of highlights, total anomalous pulmonary venous drainage, hypoplastic left ventricle, pulmonary vein stenosis, and persistent foramen oval. These all my differentials will have absence of roots. Only the pulmonary arteriovenous fistula, which is not visible in this slide, will have the roots being present. GIT examination was normal. And then what is your diagnosis at this point of time? Means
I think it will be a pulmonary artery fistula, arteriovenous fistula.
Yes, sir, because
and that can produce this paradoxical embolism and stroke.
Yes, sir.
And you said that there is a bruit in the interscapular area.
Yes, sir, which will be only.
What about the echo?
Echo was normal, sir. It was normal.
Okay, you have an X-ray chest or something like
yes,
that?
Yes, sir, I have, sir.
Yeah, so I think this should be a pulmonary arteriovenous fistula. At least that is what I think from your findings just now.
Yes, sir.
Yeah.
This was the MRI brain, which was done on 6th of January 2024. We showed subacute chronic infarct in the right paraventricular regions with lacunar infarct in the left caudate nucleus. A stroke in young Burkitt's, that is ANCA, ANS, PTINR, protein C, ACE, antithrombin 3, factor V Leiden, lupus anticoagulant, and anticardiolipin antibody that were negative, except the serum homocysteine that was 30.4.
You know, the infarcts also are in two different vascular territories. Just show that scan again. Just go back one slide. Yeah. So they are in two different vascular territories.
Yes.
So this is typical of a cardioembolic stroke. It is not a single artery stroke. It is from two different vessels, and most likely it comes from the heart or, distal to the aorta, or it can come from the aorta also, but it can usually from the heart or somewhere else, but not from the carotid arteries.
Yes.
Yep. Okay. So this scan is very important to help us, with the differential diagnosis. Yep. Go on.
2D echo, which was done, was normal with left ventricular ejection fraction 60% with no any MS, MR or ACE or ER valvulopathy was present. Venous Doppler of the both upper limb and lower limbs were normal. This was the chest X-ray. This was done. Which showed the nodular lesions in the right middle lobe as well as in the left lower lobe. And this was the CT pulmonary angiogram, which was done, which shows the pulmonary arteriovenous malformations involving the right lower lobe and a small in the right middle lobe as well as in the left lower. And this was the DSA, which was done, which showed the pulmonary arteriovenous malformation. There were 5 malformations being was present in DSA, and out of these 5, 2 were embolized. And this was the AVM post-embolization. And following embolization, there was a considerable improvement in her cyanosis. Here we can evidence this is the post-embolization figure, and there was a considerable improvement in her SpO2 with 99% on room air post-embolization when she was in ICU.
Was there
And
any marphonoid features? Because her fingers look very long. And
no, sir, there was no any morpholite features.
see those fingers which you are showing are very long. And if I'm not mistaken, I don't remember, but if I'm not mistaken, these fistulas can occur when the media and intima are not very strong, and you can get in Marfan's or in Ehlers-Danlos or similar this thing. So maybe you could look at that.
Okay.
Yeah.
And this was one of the other case which was reported in our hospital of a case of unusual combination of patent foramen ovale with pulmonary arteriovenous malformations in young patients. In these cases, apart from this patient was having infarct in the right middle cerebellar territory, we did TE which shows the PFO, and the angiogram shows the pulmonary arteriovenous malformation which was reported. And thus, these pulmonary arteriovenous malformations are abnormal communications between pulmonary artery and veins bypassing the pulmonary capillaries. Simple pulmonary AVMs have one or more feeding arteries arising from a single segmental artery, whereas complex AVMs have multiple feeding arteries arising from more than one segment. Most pulmonary AVMs are hereditary and often associated with hereditary hemorrhagic telangiectasia, and none hereditary hemorrhagic telangiectasia associated pulmonary AVM are often idiopathic, but can be secondary to trauma, schistosomiasis, actinomycosis, or hepatopulmonary syndrome. Here we can see that because of these malformations here at these levels, these bypasses the pulmonary capillaries, and thus by bypassing the pulmonary capillaries, these will enter into the deoxygenated blood with apart from the thrombus being formed here at the AVM will enter into the left atrium, left ventricle, and then into the systemic circulations. And if it lodges into the cerebellum and the brain, that can lead to TIA and a stroke. Because thus in a pulmonary AVM, because of right to left shunt, these patients often have dyspnea on exertions, but other pulmonary symptoms like chest pain, hemoptysis, hemothorax, and platypnea can occur. Neurological symptoms include TIA, hemiplegia, brain abscess, and strokes. Pulmonary AVMs causes stroke by paradoxical brain embolism. Here, the pathophysiology of stroke in pulmonary AVM because of platelet aggregations, enhanced platelet aggregations because of high level of fibrinogen or endothelial injuries, as well as iron deficiency anemia in hereditary hemorrhagic telangiectasia, as well as the enhanced coagulation cascades with elevated factors 8 and low APT levels. These will all contribute to the platelet aggregations, thrombus formations, and these thrombus will reach into the left atrium, then into the left ventricles, and then systemic circulations, and can lead to a stroke by paradoxical embolism. Thus, the diagnosis of it is transthoracic echocardiography with bubble study is the initial test of choice, and bubble can be seen in the left side of the heart, indicating right to left shunt. CT scan of the chest is the diagnostic test of choice to confirm pulmonary AVM, and can also identify the degree and complexities of pulmonary AVM. ESA is the next best investigations to confirm the diagnosis. The treatment include pulmonary AVMs with is the embolization, and pulmonary AVM with neurological complications, hypoxemia with feeding arteries greater than 3 mm in diameters are recommended for active treatment, and transcutaneous transcatheter embolization as well as surgery is the main treatment of choice for it. And pulmonary embolotherapy of the feeding arteries of the pulmonary AVM is currently the first line of therapy. Embolization with detachable balloons, metallic coils, Emcure vascular plugs is used for treatment. Complications of embolization include air embolization, paradoxical embolization of device, spontaneous balloon deflations, pleurisy, and recanalizations, as well as coil migration. Recanalization accounts for 90% of the persistent pulmonary AVMs. after embolotherapy and also the most common mechanism for pulmonary AVM reperfusion. Surgery is the treatment options for difficult to treat with embolotherapy and refractory cases with repeated failed interventional procedures. And the candidate for local excision or lobectomy include progressive pulmonary AVMs enlargement with symptomatic hypoxemia, brain abscess, diffuse lobe or segmental, and solitary large pulmonary AVM, complicated pulmonary AVMs, or life-threatening bleedings after pulmonary AVM ruptures. And thus, video-assisted thoracic surgery is for the idiopathic peripherally located simple type of pulmonary AVMs. To conclude with, advances in catheter techniques have increased the proportion of patients who are eligible for embolotherapy. However, transcutaneous embolizations cannot completely replace surgical resections in all the patients with pulmonary AVMs. Surgery as a treatment of choice strategy should therefore be considered in a specific cases to achieve complete recovery. And although the current work in the field suggests that an individualized approach is necessary for treatment of pulmonary AVM. Thank you all.
Very interesting case. Dr. Sase, Dr. Kasegaonkar, could you comment?
Yeah, I personally feel that it was a very greatly reviewed case, especially in terms of the cyanotic heart diseases and TIA. Only one thing which I would add to is that additionally multiple pulmonary AVMs are also associated with the hepatic AVMs. And maybe if the symptoms may not be there, but in future times they may have some hepatic symptoms. So ultrasonography to rule out any additional lesions like pulmonary AVMs, which may have AVMs in the liver, also could be screened into these kind of patients.
Does it, Dr. Prasanna?
Yeah, firstly, let me congratulate Dr. Ramesh Krishnan for excellent case. I mean, it was a rare case. It was very well diagnosed. I just have a question. Were there any telangiectasias to suggest that patient had any evidence of HST? Because HST is known to be autosomal dominant. And in that situation, you may require some genetic tests to look for mutations, etc. Or was it just a idiopathic AVM in this case?
So this patient was not having any telangiectasia in her. We examined her. This was the chest X-ray right from 4 years back. She also did the same chest X-ray, but since it was done in periphery, one could not diagnose that chest X-ray. When she came to our hospital, it was we took the retrospective history of her X-ray along with we rule out other differentials of the nodular lesions, and we did the pulmonary angiography on the basis of just chest X-ray findings of nodular lesions, and this pulmonary CT angiography showed the pulmonary arterial response.
Was there any polycythemia as well in this case?
No, sir, there was no polycythemia.
Right, because in chronic cyanotic conditions, there's usually some amount of polycythemia, which will again lead to hypercoagulability. That is another factor which one should consider, and that's the reason why I was asking this question.
Yes, sir, but she was not having.
How much was the HB?
HB was 13 to 14, sir.
That was good.
You know, many times, there is iron deficiency anemia in Indian population. So actually, you should get polycythemia.
Yes.
Actually, you should. But, sometimes because of iron deficiency anemia, it can get masked. I just looked up. Marfan's also is a cause, huh? Yeah. So I just looked up on the net when you were speaking and this thing. So I just confirmed. I think, as Dr. Prasanna said, you must do a genetic study. Look for Marfan gene and look for the hereditary telangiectasia gene, because it is important to make this diagnosis for further, management and further, for the next generation also. Suppose she wants to get married. There are many implications of doing a good genetic test. So, especially for a rare condition like this, certainly one would like to do that. Since when was the cyanosis?
Cyanosis was since 4 years, sir, and she was in 78% room air and was fine. Was dancing, was doing all the routine activities
Yeah, but
with
she
this
she was
78%.
breathless on climbing stairs, no?
Yes, but with routine activities, she
Yeah,
was fine.
routine activities she was compensating,
Yeah.
but with little more physical exertion, she was decompensating.
She became
So that is often the case. It's a very rare condition, but another thing, we should be concerned about, and they can get brain abscesses also, just like in congenital heart disease,
Yeah.
congenital cyanotic heart disease. Because you are bypassing the lung filter, you can get paradoxical embolism. And here, maybe it is really, actually, it is paradoxical embolism because it is bypassing the lung filter.
Yeah.
And maybe you could look for DVT. And very often, not very often, but they are prone to brain abscesses also, especially if they get septicemia when this infarct has occurred. The bacteria can seed into that area. So these would be the possibilities. Of course, a very rare case and extremely well managed, I must say. So many congratulations to you. Dr. Sase, Dr. Kasegaonkar, any more comments?
No, sir. No. It actually excellently managed. That is one point. It
No
is,
doubt.
I mean, no doubt about that. Only thing that I would still, agree with sir that we should chase this further, because if it is HST or if it is Marfan, she might have it. She will have a recurrence after a decade or few
Yes.
years also. Even in her own case, if it is just idiopathic, we close the case and we forget about it. But then later on, how do we? She may develop few more malformations or few more AVFs if the pathophysiology continues. So that is one thing which I would really agree with sir, that we should chase it down to just go ahead with whole exome sequence and see what happens. It will be very interesting to know.
Okay, sir.
One question to Ichapuria sir. Do the antiplatelets be given to this as a prophylaxis?
No, not really. Now, if there was only one fistula, no, you said, or two? How many were
There
there?
were
There were 5 fistulas, sir, on
Five.
DSA, and out
Three were-
of these, we did the embolization of 2 fistula. And with this, her SpO2 was 98%.
No,
And we
there were
prescribed,
5 fistulas, and you
yes,
closed 2.
2 1, yes.
Okay, I missed that point. So, over a period of time, they may also increase, huh?
Yes.
Yeah,
Over a period of time, just because the cyanosis went away, that doesn't mean the fistulas have gone away. So maybe over a period of time, you may have to close the others. I see no harm in giving antiplatelet.
yeah.
She
Uh,
was prescribed 25 equisprine also.
what?
Uh,
Say that again?
equisprine 75 was
Yeah.
given for her.
So,
And she came on the follow-up also.
another thing is, they can get, I mean, see, this is a paradoxical embolism. It's bypassing the lung filter. So it's like a PFO.
Yes, sir.
So it may be coming from the legs or it may be coming from the pelvic veins. So we must look at the lower limbs also, see if there is any thrombus.
We did the venous Doppler also on the
Ah,
both, that was normal.
correct.
That's why.
So very often lower limb Doppler may be normal. Sometimes it comes from the pelvic veins also.
Yes.
Correct.
And many of these young women are on this thing, hormonal
Oral
tablets. Yeah,
contraceptives, yeah.
for controlling periods or for controlling birth. So that also should be avoided because it's like a procoagulant state in a way. But certainly one will need to follow up those other 3 AVMs, huh? Because
Yes.
over a period of time they will increase.
Yes.
So it's not the end of the story. And you'll have to do a proper follow-up for a period of time.
Yes.
Yes,
So-
Dr. Sase.
One more question is that how do we explain the aphasia which she presented with?
She must be having recurrent emboli, which then dissipated. because already we are seeing two infarcts in two
completed
different
infarcts.
territories.
Yes.
So maybe she's showering emboli. Some of them are silent, or most of them are silent. But when they go into an eloquent area, they produce symptoms. So luckily, it didn't stick there forever. Otherwise, she would have had a stroke. But it dissipated, and maybe it was fragile. So she got a TIA. But certainly, I would give antiplatelet prophylaxis. Maybe even, I don't know. If we find DPT, then anticoagulant.
Yeah.
But as of now, antiplatelets, I think, is okay. But follow-up is necessary, and because the other ones can get, they can produce symptoms again. So it's very surprising that there are 5, AV
Yes,
fistula.
on CT angio, there was only 2 to 3, but when we did the DSA, we got the 5.
So that means there is some underlying, it's not just a one-off malformation. That means there is some vasculopathy. The very fact that there are 5 means it is a vasculopathy. It is not just a single malformation, A single malformation can occur by chance. But 5, if they are, then definitely we should think of a vasculopathy. What do you say, Prasanna? You agree with that point?
I would fully agree. We have seen 5 which are macroscopic, right?
Huh?
So there could be, we have seen 5 which are macroscopically seen.
Yeah,
There must
may be more.
there could be another dozen which are not seen
Yeah.
on
So it
on
looks
field.
like a vasculopathy, of some sort.
Yeah.
I mean, not the protein SC type. Those are the coagulopathies, but
but the collagen
this is a
disorders,
weak
collagen
vessel.
disorder.
This is a weak vessel.
Absolutely.
Yeah. So certainly chase down the genetic part. Huh?
Okay, sir, we will.
Tell Dr. Ranjan, give him my
Okay.
best wishes.
Okay, sir, I
He's
will.
an old friend of mine.
Okay, sir, I will.
Yeah, tell him that I am congratulating him on the excellent management also. And we would like to take it one step further.
Okay, sir, we will share your wishes.
Yeah.
Yes, sir.
Okay. Anything else, sir?
Nothing more to add, sir. Excellent presentation.
Excellent.
Thank you, sir.
I told you that, we learn every time from these things.
Something new.
Now, I've done so many of these programs, and every time I learn something new. So I'm sure you all are also quite impressed with the lovely presentation. Thank you, Krishnan.
Thank you, sir.
Thank you. Yes. Dr. Pandey?
Yes, sir.
Yeah. Could you go ahead, please?
Dr. Namra, please let the team to share my slides, please.
Or will do.
You can try, sir, now.
Okay, make it full screen. Hello, everyone. Just make it. Hello, everyone. My case is a simple case. It is a case of a blood clot and clot, both in the simultaneous presentation in an emergency room of a hospital. Next. As you know, Mr. Satish Kapoor, who is a 79-year-old male gentleman, presented to our emergency with multiple episodes of vomiting, heavy head, and mild imbalance, constipation for few weeks. He developed sudden stiffening of the body with unresponsiveness on a particular date, that is 17th of April, and which recovered after 5 minutes. Another history of such episode is there on the after one day again on the 18th, and which the time of recovery is slightly increased, that is 15 to 20 minutes. Patient then came to the emergency of the hospital for further management. Next. On examination, the patient is if afebrile, pulse is normal, 99% blood pressure is 147/63, and on the cardiovascular and respiratory examinations is normal, and on the central nervous system examination there is no particular focal neurological deficit, and only there is a mild cognitive impairment is there, and power is normal, and there is but the both planters are extensors, and there is a mild gait ataxia is there. Next. On CT scan, we will find there is a no acute infarct or hypotensity is there, but there is a mild subtle hemorrhage, or we would conclude at the age of a 79 it could be some calcification of the falx is there. So we do then MRI scan. Next. We will find that on MRI, there is a small dot-shaped diffusion restriction area on the right parietal area, right parietal region, pointed by this, and which shows the restriction on the other side. And next, and there are multiple flare hyperintensities, but on the gradient that there is SWI images, there is a full-blown SDH is there, and multiple subcortical subarachnoid hemorrhage is there on the both sides. SDH na SH is there. Next. Now, on the conclusion of on seeing that images, we do certain we do MR angio and MR venogram. Both were normals. Investigation, the baseline investigation we had done, that is also in the normal limit. And then on the view of the this unresponsiveness of the two episodes in a old aged man, and with an MRI finding of the above gave one clot and a certain amount of bleed in a cortical area, we put on an anti-epileptic medication, assuming that it could be a case of a cerebral amyloid angiopathy. And however, the patient becomes become restless with the dose of Levipil we have added. So we have changed to the Brevipil, and after that, the patient respond to the treatment well and happily discharged to his home. Regarding the discussion part, next. These are the well-defined criteria for the cerebral amyloid angiopathy. These are the previous criteria that was again modified. It was divided into possible cerebral amyloid angiopathy below, in which there are CT and MRI finding, and the age of the patient should be more than 55 years, and the typical distribution of an hemorrhagic part is a single lobar region, not in the subcortical region. Subcortical hemorrhages are considered to be the finding of an hypertensive changes, not of the amyloid changes. And other category is the probable cerebral amyloid angiopathy, in which there is a multiple hemorrhages with restricted to the lobar cortical areas, and age is also is there greater than 55, and there is any other obvious cause of an hemorrhage, like in hypertension, or there is a AVM malformation or extra. And the third category is probable cerebral amyloid angiopathy within supporting pathology. Supporting pathology means that we have isolated the tissue, or there is a large lobar hemorrhage which is evacuated and sent to the cortical biopsy, and we get something which is suggestive of this cerebral amyloid. The criteria same: lobar, cortical distribution, and absence of other diagnostic lesion. And the last category is the definitive cerebral amyloid angiopathy, which is a postmortem finding. Next. This is a modified Boston criteria, which is used for which is the modified version of the previous category, in which there is a more transient. There is the presentations, and could be like cerebral amyloid, could be in ICH or a convexity SAH, or there is a transient focal neurological episodes. That thing we are assuming in our patient, that it had a transient focal neurological episodes along with some mild cognitive decline. Age is definitely criteria, that is modified one is greater than 50. MRI evidence, the same category is there, but there is a slight modification mainly on the visual basis. In the category A, there is a probable cerebral amyloid angiopathy with greater than 2 strictly lobar hemorrhagic lesion, whether it could be ICH or whether it is a cortical bleeds, whether it is a cortical sidrosis, superficial sidrosis, or is a cortical subarachnoid hemorrhage. In our case, there is a cortical sidrosis is present in the frontal region, and or there is another criteria, strictly lobar hemorrhagic lesion with some white matter changes. White matter changes we see in the form of a white matter hyperintensity in the flare lesion, in the flare images, or there is a significant centrum semiovale perivascular region over direction that we can see in a T2 images. And the last, the possible CA is a strictly lobar hemorrhagic lesion or one might better changes. And fourth category is absence of any deep hemorrhagic lesions, just like a cerebellar lesions. And absence of other cause of hemorrhagic lesions, just like a patient is previously on oral anticoagulation or other extra. Okay, thank you. The take home message from this thing is like, if the patient came to a history of scissor, atypical scissor or a negative TIA, you have to consider for other scans just like an MRI. So we could look after this rare entity of an or the cause for this TIA, just like a amyloid angiopathy. Thank you.
Yes, Dr. Prasanna.
Excellent presentation. CA looked straightforward, and as you started presenting, did we proceed with anything like abdominal fat pad biopsy to get some
Actually,
other evidence of amyloidosis?
we have planned to do for that thing, but the patient we doesn't get consent for that, and patient has only stayed for only 1 day. Yes, patient feel I am okay, and why to there is a need for staying in the hospital. We cannot even with the cerebral amyloid finding is just after going through the literature after the patient has discharged. That's why we concluded that this thing like could be the one of the possibility.
Right.
So say.
What happened to the subdural hematoma?
Subdural hematoma is not there. Sorry, I have pronounced it wrong, sir. It is it is a subarachnoid hemorrhage is there, and it is superficial sidrosis is there. So we
I
doesn't
think instead of saying subarachnoid hemorrhage, you should say superficial siderosis.
sidrosis. That is the
So,
part.
that subarachnoid hemorrhage, of course, it can occur. Cortical subarachnoid, cortical. You
Cortical.
see,
Yes.
when you get, when you have CAA, you have a cortical subarachnoid hemorrhage. You don't get hemorrhage in the basal cisterns. So that is a very, very important distinguishing factor between bleeding. And the bleeding is usually very small.
Yes.
And very importantly, whenever you get a TINA, you should do an MRI. You should not waste time with the CT scan, because the MRI can show you small DWI lesions.
Yes, sir.
I'm a little surprised that you didn't. If you show me that MRI again, were there microhemorrhages?
Definitely, sir. Team.
No, just show that MRI again for everyone.
Namra, please show the MRI images.
Because usually there are multiple microhemorrhages, and one of these cortical microhemorrhages, they leak, and they can produce over a period of time, not acutely.
Yeah.
Just let me see that. So see.
This one.
Yeah.
6. Next.
Show the next one.
Next one.
Yeah. Now you see superficially in the middle one, you can see these small microhemorrhages.
Yes, sir.
Right. Dr. Shishir, can you point them out? I can't point them out. Go up. Yep. Go little anterior.
This one?
Yeah, that one. Then go posterior a little bit and to the right. Go posterior and to the right.
Right.
Yeah, go down. Yes. To the right of that arrow. Yes.
Right.
Yeah. Then go down and to the left.
Out here.
Go down and to the left. Yeah. Go left a little bit.
Little left. Yeah. This one. Yeah.
There. So there are these small microhemorrhages, And this black thing that you see, that is a superficial
Yes,
siderosis or maybe superficial subarachnoid hemorrhage, and nothing in the basal cisterns.
definitely.
Nothing in the basal cistern. So this is typical of amyloid angiopathy. And it is, and you said, yeah, you said he had mild cognitive impairment. So
Mild.
that is, that is another feature. They have cognitive impairment and they may go on to Alzheimer's disease. And sometimes these, the CAA becomes inflamed, and the treatment is to give steroid and
Steroids.
immunotherapy.
Definitely we have to.
Yeah. So, this can, what is that called? CAA, carry.
Carry.
CAA, carry. So you have to give immunotherapy. And some of our cases, we have given cyclophosphamide and steroid, high-dose steroid, because they get inflamed and they get encephalopathic. They can get convulsions. They can, what is the long form of carry? Yeah, we'll just tell you the long form of carry. So this is a very interesting thing. And when carry occurs, usually prognosis is not good, and they don't survive for very long. It's quite a malignant disorder when carry occurs. And the treatment for these TIAs is not aspirin. The treatment is levetiracetam.
Levetiracetam.
Yeah. It looks like a TIA. So, you will say, oh, give aspirin, clopidogrel. In fact, the bleeding can increase because of that. So the treatment is not to give antiplatelet, but the treatment is to give anti-epileptic. An anti-epileptic out of them, levetiracetam is advised. But, in elderly people, it can produce
psychosis,
cognitive impairment and behavioral change even more. So you have to be little careful with what you use.
It's CAA-related inflammation, sir. That's
Carry is cerebral amyloid angiopathy related inflammation.
Right.
So, that is carry. So it gets inflamed. So therefore, because it gets inflamed, you have to give immunotherapy. So this is a very, very interesting disorder. And I'm very glad that you brought it up because it's unique. It's not often that we see it, and it's not very well known amongst many people. So I'm very, very glad that you brought it up.
Thank you, sir.
And can you tell us something more about it than what I have said?
Actually, the things, most of the things you have covered, sir. The inflammatory, but the treatment is not the antiplatelet. We have to manage it with the anti-epileptic medication.
Correct.
And if the inflammation increase, we have to give a steroid. Ideally, if the TIAs are more frequent, just 1 or 2, we have to start with a low dose of an anti-steroid
Low dose of?
Low dose of a steroid.
Yeah.
When this frequency of this TIA increases, there is a predictability that it could get more inflamed.
So, I told you that one patient we had not very long ago, and we were really struggling with him. He initially came with a seizure. He was an elderly man, about 75. He came with a seizure. Then he became encephalopathic. He developed dementia. And he was getting recurrent seizures. And this MRI showed extensive siderosis and inflammation. And then, he was going downhill because of decreased sensorium and encephalopathy. And finally, we had to give him cyclophosphamide also, But I think he survived for 6 to 8 months. And so it's quite a bad disorder when it occurs. So we should be aware of it. And it's a unique thing because, few years ago, maybe 5-7 years ago, we didn't know much about it, but things are evolving, and it's definitely a differential diagnosis of TIA in the elderly. So, if you find normal vessels, normal heart, sometimes, if you miss doing SWI scan, You will miss the whole thing.
Yeah.
So in any TIA, you should do diffusion and SWI to find out this particular condition.
Definitely.
So I think very interesting. Dr. Sase, Dr. Kasegaonkar, any comments?
It's actually a clinical, pathological, and radiological features together would diagnose that. So I think it's a clear suspicion at the beginning of the investigations and if we suspect that at the beginning only, then the line of treatment and probably a diagnosis would be better. So it's a good lesson to learn that all the TIAs should not be treated with antiplatelets, but suspect and especially, as you said, sir, that MRA should be done in all the TIAs. So I think that will help us to pick this diagnosis more frequently than in the past.
Yes, Prasanna?
Yeah, fully agree with you, sir. I mean, there was, I was just aware of the term CARI, but the presentation and its aggressive nature actually I got to learn from you. So as you just said at the start of the talk itself, there's so much to learn. So
You know,
just
these younger neurologists, no, Prasanna, they will beat us hollow, yeah.
yeah.
अपने को तो यार, we didn't know all these things, but these young guys, no, they are going to beat us hollow, yeah.
I agree. Fully agree.
So
Well done, Shishir. It's an awesome case. It opens up, new thoughts. A few new things come up. There's always something to learn.
Thank you, sir.
yeah. Dr. Sase, any closing comments?
Good session to learn so many things, and I think would wish to join many times so that we can learn more things. And thank you for the feast this evening, sir.
Yeah. So both of you come more often as moderators, no, yeah.
Yeah, sure. I'll look
How
forward
many
to it.
invitations to give you all?
No. We will definitely join because we learn more. That's what I find.
Yeah. I'm telling
I
you, every time I'm here, I learn something new here, and we see something exciting, and you'll be amazed what things we have seen.
Yes, sir.
Namra,
Sure.
can you take it forward?
Definitely. So thank you so much for providing time for this meeting, and we are extremely grateful to you for the same. We had wonderful moderators today, Dr. Prasanna sir and Dr. Nathaniel sir. It was great to have you, sir, today, and we look forward to such collaborations in future again. And thank you so much, Dr. Shishir Pandey and Dr. Ramesh. For the case discussions. They were I'm sure they might be very fruitful and helpful to the audience. So today we are live with the 256 attendees.
Oh, wow. That's great.
No, that's not good. We usually cross 400. Namra, how much we are at 354, 400 usually.
Yes, every time it's 350, 400.
So ye time to jara kam hai. We are a little less. But anyway, 250 people, Ramesh and Shishir, now they know you, yeah?
Thank you, sir.
And
Just
they'll look up to you. So that's great. Any questions from the audience?
No.
No questions. Okay.
No questions, sir.
Okay, great. So thank you. It's 9:30, 1 hour proper. And thank you, Dr. Sase, Dr. Kasegaonkar, Dr. Pandey, Dr. Krishnan, and Namra. Thank you for anchoring the show and having us learn so many new things.
Thank you, sir.
Thank you so much for being associated with us, sir, on this platform, on the educational platform. Thank you.
Thank you.
Thank you. Bye-bye. Bye. Good night.